Hi everyone, and welcome to this video on the 3 different classes or categories of diuretics. So in this video, what will you learn? You'll learn the 3 categories, specifically their modes of action or mechanisms of action. So how do they actually work? We'll look at why they're prescribed, why they used clinically. So these are the clinical indications or the therapeutic indications. And then finally, we'll finish off on their most common adverse effects. Now, the way I'll explain these diuretics is through the function of a nephron. So remember, the nephron are the functional units of the kidney. We generally have 2 kidneys. Each kidney has 1 million nephrons. So the nephron is the functional unit for the kidney. It does the filtration, it does the reabsorption, it does the secretion, which is important for that homeostasis. So as we go on the journey through the nephron, I'll show you 3 distinct regions, and these 3 distinct regions are where the diuretics work. So firstly, just get a head around what a diuretic is. A diuretic is a medical or medicine that induces diuresis. Diuresis essentially means the excretion of a solute and then the water will follow. So what you'll expect to see is more types of solutes come out. In today's case, this will be sodium and chloride, and also an increase in volume of urine. This is going to expel or get rid of excessive fluid in the body. So the reason for why we use diuretics is generally to get rid of excessive fluid in the body, which we term edema. This could be edema in the lungs, pulmonary edema in the abdomen, ascites, or edema in the body, which is pulmonary edema. This can come about from congestive heart failure, so the heart's not working, so we have a congestion of fluid. Something's happened in the lungs to cause cause fluid to go into the lungs. Something's going wrong with the liver, which causes fluid to accumulate in the abdomen, or maybe something's wrong with the kidney and then fluids accumulated in the body. So that's the crux of why we might want to use a diuretic. Now let's kind of go to a quick overview of how the nephron works, and then we'll make better sense of how the diuretic works. So a blood vessel will come into the nephron and wind itself around in what we call the glomerulus. So the afferent vessel comes in a bundle of wool or a bundle of yarn, which we call the glomerulus, and then the exiting pipe or the exiting blood vessel is called the efferent, and then that efferent follows the nephron along its tubule and its journey to help with the reabsorption of certain solutes and water and those kinds of things. So the way that the kidneys, through these 1 million to 2 million nephrons work, is blood comes into it, and the way it filters it is it just pulls all the plasma out. So the whole entire plasma in the blood comes out, and then it decides on what it wants to reabsorb. So if you look at all the kidneys collectively through the whole day, we are filtering about 180 litres of filtrate. So that's a lot of plasma we are filtering. So that's telling you we need to reabsorb most of it. So about 99% of the stuff that comes out, we need to then put back into the blood. And this is what the function of the nephron is, to pull the plasma out, which then becomes the filtrate, and then the filtrate goes on a journey to essentially to get 99% of the stuff back in. But today we're only going to focus on sodium chloride. So of the 100% of sodium chloride that comes out, in the first part, which we call the proximal convoluted tubule, about 65% of it is reabsorbed straight away back into this part of the nephron. As we continue on in our journey, we go down the loop of Henle and we come back up to what we call the thick ascending loop, which is where we have our first location of the diuretic, which is going to be this section here. We have about 25% of sodium chloride being reabsorbed. And it's important to note that where salt goes, water will follow. So this is going to be important for the reabsorption of salt and water in this region. So 25% of that is occurring there. Then we move on to the distal convoluted tubule, and this is almost the last part of the nephron, the distal convoluted tubule, and here is about 7% of sodium chloride is reabsorbed back into the blood. And then finally, we finish off with the last part, which we call the collecting tubule or the collecting duct, and about 3% of sodium chloride is reabsorbed there. So what you can see is we have 3 distinct regions on the nephron which will end up becoming where the diuretics work. It's important to note that the way that diuretics will work is blocking the reabsorption of the sodium and chloride. Therefore, water can't go back with it. Therefore, more sodium chloride and more water ends up into the toilet. And that's a way we get rid of excessive fluid in the body. So let's start with region 1. So this is the thick ascending loop, okay, and this is where we're going to have the loop diuretics. So number 1 is the loop, and I'll just put loop diuretics. So this is the first category, loop diuretic, and I'll also put it up here, loop. And the most important drug to be aware of here is furosemide. Okay, so furosemide is the drug we're talking about here, which is the loop diuretic. Now, what we can see in the thick ascending loop, so the filtrate is moving its way along here, okay, and it's going to be changing its concentration of things as it's moving along, and all the things are jumping back into the blood. So we saw already in the first region, 65% of salt, sodium and chloride is being put back into the blood. So as we continue on our filtrate journey and we come down the bottom of the loop and coming back up, we're starting to hit all these cells along the thick ascending loop, which I'm going to bring across here and zoom in here. So this part here is in the actual filtrate side, and this part here is the blood. Okay, so the first thing I'm going to draw your attention to is at the basal surface of the tubular cell, we have a pump. This is a sodium-potassium pump. Now this is important because what it does is it drags sodium out and dumps it into the blood, and we put potassium back into the cell. This generates a low sodium count inside the cell, which becomes important for the gradient of bringing sodium and other electrolytes into the cell, out of the filtrate. Now, by generating that pump, what we then have is sodium, chloride, and potassium wanting to follow a gradient to come into the cell. So that's out of the filtrate, so out of this area, into the blood, through the cell. And it's generated by the gradient that is made by the pump. So there's actually a transporter here, which we call a co-transporter, that is driven by the gradient of sodium. So sodium drives the transporter, but it also sucks across with it 2 chlorides and 1 potassium. So all of these solutes come across this co-transporter into the cell. Then we see the sodium getting pushed across. We also have another channel here, which is for chloride. So potassium can go out there, chloride can come back in, and we also have another small channel here for potassium to come back out. But the important point I just want to bring to your attention here is this co-transporter. And this is where the first diuretic is going to work. So the first diuretic is actually going to stop that co-transporter. So that's the loop diuretics, or that's the furosemide, so it's blocking that transporter. So its mode of action is to block the sodium, potassium, 2 chloride co-transporter. Okay, so that's how it works. That's its mode of action. It blocks that transporter. That means sodium can't get in, chloride can't get in, potassium can't get in. So that means they stay in the filtrate. They stay in here, which instead of normally being reabsorbed into the blood, which makes that fluid hypotonic, which means less solutes, we now stop that process. So instead of getting 25% of that salt back into the blood, it stops. So that then the fluid that's coming up is much more salty. And as we know, with salt, water follows. So water's going to go out with it. And this is ultimately why we're going to give this type of diuretic. This type of diuretic, the loop diuretic, is the most powerful diuretic because it's going to generate the most amount of volume to follow the most amount of salt. 25% of that salt is going to end up in the toilet with all the water with it. So we're going to lose salt, but also quite a big volume of fluid. So the clinical indication, why would we use this clinically? We would use this for states of heart failure, particularly where there's congestion. So heart failure, we'll use it, so that could be also be pulmonary edema. We could use it with liver failure or liver cirrhosis where there is ascites. Ascites just means fluid in the abdomen, and certain renal conditions, I'll just say renal disease, where there is, again, excessive fluid being retained. In some cases, that might be also used for hypertension, but it's not going to be a mainstay or the first choice for a drug of hypertension because we are losing so much fluid with this particular case. So it's more going to be used for cases where there's fluid retention in the body. Now, the side effects is because we're losing lots of fluid and certain electrolytes. So the best way to remember for the adverse effects is, I'll call it the 5 hypos. The 5 hypos. So we have a risk of hypotension. That means a drop in blood pressure. Well, actually before hypertension, I should have said hypovolemia, which means we've lost a lot of volume of body fluid. So hypovolemia is a risk. Then hypertension would follow, particularly in the elderly. So this is running the risk of them collapsing or fainting because they've got reduced volume, therefore reduced blood pressure, therefore no blood to the brain that they collapse. So that's a risk there. But they're also going to lose lots of potassium. So we can get hypokalemia. Now, because we're also flushing a lot of fluid out, as the fluid's rushing past the last part of the nephron, this part of the nephron is also important for handling acid-base balance. We're losing hydrogen as well, but not with bicarbonate. So what we actually see is we lose hydrogen, we lose fluid volume, so our plasma volume shrinks or contracts, but we don't actually lose bicarbonate. So as a result, we get low acid, which we call metabolic alkalosis, because we're losing an acid, retaining the bicarbonate. So we've got hypovolemia, hypertension, hyperkalemia. We can also lose some other electrolytes like magnesium and also sodium, so that would be a hyponatremia. So as you can see here, the adverse effects or the things you need to be mindful of is losing too much fluid, therefore getting low blood pressure, also losing potassium, that's probably the bigger risk of the electrolyte imbalance, but also metabolic alkalosis, losing too much sodium, losing potentially also magnesium. So that's the loop diuretic. Moving on, we go to the second part, or the second location of it where our diuretic is going to work. This is going to be in the distal convoluted tubule. Okay, so here we generally will reabsorb only 7% of our sodium chloride, which is a lot less than 25%. So this is going to be less powerful diuretics when compared to the loop diuretics. These diuretics is what we call the thiazides. The thiazide diuretics, I'll write it in over here, thiazides. An example is hydrochlorothiazide. Okay, so that's an example of a drug, generic drug, the hydrochlorothiazide. Now, the way that this particular drug works, actually, I'll go through the physiology first. So as the fluids come in normally, so let's say this is just normally function, as the fluids come up here and we've done all the reabsorption as we should, the solutes and the filtrate is actually hypotonic. We don't have a huge amount of solutes in here, and it's more watery than high solute concentration. So what's actually going to happen in this region is we have, again, a pump on the basal surface. So here's the blood vessel. So the blood vessel would be on this surface here. And again, we have a pump which generates a gradient. Sodium goes into the blood, potassium gets put into the cell. This causes a low sodium internally in the cell. Therefore, sodium wants to go into the cell through a different transporter. This time it's a transporter for only sodium chloride. So it's just a co-transporter for sodium chloride. This drags the sodium chloride into here. We have a similar arrangement of things here as well. So we also have a potassium chloride channel here. So potassium can go back out into the blood and chloride can come in. And we also have a potassium leaky channel here, which can go into the tubular side. But where I want to draw your attention is the pump is important, but the co-transporter is the one that brings sodium and chloride back in, which is reabsorption, that's 7%. Now, the way that thiazides work is blocking that co-transporter. So the mechanism of action of thiazides is to block the sodium chloride co-transporter. Okay, so now as a result, sodium, chloride, and some potassium will remain in here, and as a result, it will be flushed out. So why would we want to use these drugs? Well, they're going to be a lot less potent than we see in the loop diuretics. So you can use it for some of these cases like heart failure, but most commonly it would be used in hypertension. So thiazide diuretics would be used in hypertension, not the primary first drug. Usually the ACE inhibitors go first, but the thiazides can be used in conjunction to other blood pressure medications, and it can also be used in certain cases of heart failure, and it increases the survivability in heart failure in certain cases. The side effects associated with it is going to be similar to these, but on a smaller scale. In addition to all those hypos, but again, they're going to be less exaggerated. Much more common in loop diuretics is these things you'll see, but you will get a loss in potassium. And you also run the risk of metabolic alkalosis, not to the same extent, and also hypertension, not to the extent, but you can also, a common adverse effect, or relatively common, is erectile dysfunction. I'll just put ED, erectile dysfunction, can go with the thiazides. So that's where the thiazides work. Lastly, we come across to the last group of diuretics, and these work in the collecting tubule or the collecting duct. This is only working with about 3% of sodium chloride reabsorption. So they're not going to be very strong diuretics here because we can only really get 3% of that final sodium and chloride back in. So if we use a drug and that sodium chloride remains in the tubule, it will only pull a modest amount of water with it. So these aren't going to be powerful diuretics. But what they're going to be used for is potassium sparing. So I'll call them potassium sparing diuretics, because you're not going to lose potassium by their mechanism. Okay, so that's the benefit of this classification of diuretic, is you're not losing potassium like you saw with these other two. And that's going to be the distinction we see with why we would use this type of diuretic. Now, just quickly to point out how this would work. Normally at the collecting tubule, what we see is another pump. Again, the pump is associated with the blood vessel. So the pump, the ATPase pump, is putting sodium back into the blood, potassium back into the cell, generating a low concentration gradient or in the cell. So sodium wants to enter the cell to follow its gradient. So it will be pulling that last 3% of sodium with it. Okay. Chloride's not so much involved here. Other things that you will see here is this is also where ADP works. So antidiuretic hormone, ADH should I say, not ADP. Antidiuretic hormone works here, and this works by adding more water channels on the top surface and the bottom surface of it, so it can pull the water out as the last ditch effort to get water out of the tubule into the blood. But also we have at this pump level is where the hormone aldosterone works. So aldosterone comes from the adrenal gland, Aldosterone is a steroid hormone, so it essentially makes more of these pumps. If you make more of these pumps, you can generate more sodium drag. More sodium means more water, means more reabsorption, which is important for blood pressure. So, in the case of the diuretic use, the two ways that the drug works, we have the potassium-sparing drugs that work by blocking the effect of aldosterone. So we have kind of an aldosterone blocker potassium-sparing drug, or we have a potassium-sparing drug that blocks this sodium channel. And so there's kind of dual action potassium-sparing diuretics, either through the pump or the channel. Now the names of these drugs, so I'll write it down here. So the category is potassium-sparing, but the two subtypes, 1 and 2, is amiloride. Amiloride works by blocking the sodium channel, and spirolactone works by blocking the effect of aldosterone. Okay. Now the mechanism of action, that was the name. Mechanism of action is the sodium channel blocks. Sodium channel, that's for amiloride, and for spirolactone, it's blocking aldosterone. And remember that aldosterone is that hormone that comes from the adrenal gland that is usually there to increase our body fluids, increase our blood pressure when we're in cases of maybe dehydration or we're having trouble maintaining our body fluid levels. Now, why would we use it? Generally, why we would use potassium-sparing diuretics is we use them in combination with the other diuretics, but when there is low potassium. So if you're using a loop diuretic for one of these causes and your patient is now losing or is low in potassium, you might add a potassium-sparing diuretic to it. Or if your patient's using a thiazide for hypertension and they're becoming hyperkalemic, you might add one of these diuretics to it to increase the potassium back in. So it's usually in cases of low potassium. I'll just put low K with other diuretics. Where it may be used kind of in isolation is where you have conditions where there is huge amounts of aldosterone in the body. This can come about when there is maybe a tumor in the adrenal gland releasing high amounts of aldosterone. Therefore, you're going to be producing lots and lots of pumps. Therefore, you're going to be getting high blood pressure and reabsorption of a lot of fluid, but you're also going to lose a lot of potassium that way. And so using something like spirolactone might be used in blocking the effect of hyperaldosteremia. Now, the adverse effects, surprise, surprise, the opposite, increase potassium. So the patient might actually become hyperkalemic. So that's obviously a consideration you need to have because both low or high levels of potassium is concerning with the excitable tissues. So that's the heart and muscles, the nervous system. So these are things that you need to monitor, particularly if there's other drugs on board like digoxin or things that also affect potassium levels that you need to be mindful of. So hopefully from that video, you now can understand the three most common category of diuretics. That's the loop diuretics, the thiazides, and the potassium-sparing. How they work, blocking different channels and different co-transporters. Why are they used? Remember that a diuretic is usually something that induces diuresis, so getting rid of excessive fluids. But as you can see, it's going to be also used in hypertension and in cases where we're using a diuretic and we have low potassium. And then we also see some of the adverse effects, not all, but some of the common adverse effects that are associated with these diuretics.
Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMikeTodorovic. Speak to you soon.